Hello everybody, this is Alexander Damron. In this video we're going to be covering HER2 immunohistochemical analysis of breast cancer, and specifically I want to go through the steps that I take when I approach these cases, because if you study breast cancer and you're into breast pathology, you know that HER2 interpretation is not necessarily as easy as it seems, right? Things kind of straddle the lines between 0 and 1 and 2 and 3 plus, and often we're put in that scenario, do I call this 3 plus or do I call it 2 and get CISH? And sometimes you're like, well, I'll go CISH, and if that's amplified, I guess it's positive, right? And understanding HER2 and really what you're trying to display to the clinicians is very important, because you're making a very big decision, right? And that decision is, do I think this patient's going to respond to HER2 targeted therapy? And that's a lot of importance, right? Because HER2 anti-targeted therapy, trastuzumab, Herceptin, is really a great drug. These patients that have really strong HER2 positive disease respond very well, but your role is to tell them, is this patient going to respond? Does this patient have a chance of responding? And hopefully, as I break this down for you, everything that I say will make sense. And of course, if you have any questions, please leave a comment or anything like that, and I'll definitely try to respond to you there as well. So let's go ahead and get started. So just briefly, we're going to, very quickly, one slide, just give a brief intro about HER2. We're not talking about HER2 as a whole. We're really trying to focus on the IHC scoring. This is geared for us pathologists, residents in training, maybe those of you that are in general practice that don't do a lot of this, or, you're just trying to brush up on it, things like that. And the first thing that we're going to do after that is I'm going to go over a few morphologies where you can kind of have an expectation, right? What should, be HER2 negative almost always, and what cases have a higher propensity to be HER2 positive. I'll show you just a few of those. That can kind of make you think if something's right or wrong, right? If something is HER2 negative, do I order a HER2 repeat marker on the excision, things like that. And then we're going to go over the current American Society of Clinical Oncology, the current guidelines for HER2 IHC scoring, and we'll go over and display some of the cases that fit those exact criteria. And then after that, we're going to spend the bulk of the time talking about some unusual scenarios, some borderline scenarios, things that are going to give you trouble, to hopefully give you some, guidance as how to approach these cases, what I do when I approach these cases, and what I'm trying to relay to the clinicians. So just briefly, HER2 IHC testing is part of that prognostic information that we use to help determine the clinical course of patients, in the sense of what treatment are they going to receive to help them in their journey through this disease, right? And HER2 protein overexpression specifically is a predictive factor for patients that may benefit from HER2 targeted therapy, such as trastuzumab or Herceptin. And the overexpression in these tumors by HER2 is actually associated with a more aggressive disease and a poor prognosis. I would say, not historically, but quote historically, because now with the HER2 targeted therapy, patients that have true strong HER2 3+ overexpression respond so well to Herceptin, and it's amazing that these cancers get completely wiped out by the time they're excised. So it's very important that we identify these type of tumors so that these patients can respond to this beautiful treatment that is available to them. And while the HER2 IHC grading has been established, right, the ASCO guidelines and all these things are established, if you practice and if you sign these things out, you know that it's not that easy, right? HER2 interpretation can actually be a very challenging thing. There are cases that kind of straddle that line. Do I call this 2+ or do I call this 3+? Is it enough? If I call it 3+ and then the ISH is not amplified, is it still 3+? Right? These are questions that we have. Is that patient going to respond? These are the things that kind of really make you think about these cases and wonder where to score them. And hopefully I can help you in that process. So first off, I just want to briefly cover some histologic morphologies that you'll see that are typically HER2 negative. And the reason I want to bring this up is because with the new 2018 guidelines that have come out, they say, you don't necessarily need to repeat HER2 testing on the excision specimen of biopsies that have this morphology. And I'll say that with just a little kind of tidbit, because me personally, I tend to repeat everything that's negative on the excision for two reasons. One, I'm in community practice, and also the oncology pathologists, if you don't repeat it, they'll often ask you to repeat it, right? If you're in the academic setting where the patient may have had their biopsy there, they're going to have their surgery there, they're going to have their oncologic treatment there, maybe not necessarily as, thorough in the sense of you repeat it on everything, right? Because all of it is in-house, all of it's there. But in the community setting where these patients may have had their biopsy at X, they have the surgery at Y, and they're going to Z for their oncologic treatment, it becomes important for me personally that I have a report that has all the information in it. That way, if that report goes anywhere, it's not me referring to other reports. So personally, even in these scenarios, I personally repeat it. But with that said, there are certain morphologies that typically are almost never going to be HER2 positive, and that's going to be your tubular carcinomas, right? These carcinomas that are very well differentiated, tubule formation, low nuclear grade, these tubular carcinomas, and this is just a couple examples that I had of tubular carcinoma and cribriform carcinoma. They're very unusual that these would be HER2 positive. Other morphologies that you wouldn't expect to be HER2 positive is a mucinous carcinoma, right? And that's a pure mucinous carcinoma. I'll show you another thing like mucinous and micropapillary carcinoma, but really mucinous carcinoma that fulfills that criteria of being, quote, a colloid carcinoma is generally going to be HER2 negative. Again, there's another tubular carcinoma picture. And kind of classic lobular, your grade 1 lobulars, they're typically going to be HER2 negative, right? These lobular carcinomas are almost never HER2 positive. And as well as adenoid cystic carcinoma, which typically isn't HER2 positive, but it's also not ERPR positive, right? That's typically going to be triple negative. The flip side of the coin are, lesions that have a higher propensity to be HER2 positive. Now, still, most of these will actually be HER2 negative if you, look at the overall biomarker status. But cases that, and I mentioned earlier about mucinous carcinoma, but keep in mind there are these, quote, carcinomas that have mucinous but yet micropapillary features. Okay, this is also micropapillary features, and we're not going to go over the histologic morphologies of breast cancer in this lecture, but just know that micropapillary tumors have a much higher propensity to be HER2 positive than tumors of the same grade that aren't micropapillary, right? So micropapillaries tend to have about a 50% chance to be HER2 positive, as well as carcinomas, apocrine carcinomas. Okay, apocrine carcinomas tend to have a higher propensity to be HER2 positive. And then as you approach the higher grade of tumors, say, kind of just a general rule of thought, right? The uglier a tumor is, then you have a higher chance of being a HER2 positive tumor or a triple negative carcinoma. And just a couple examples of that. So, right, this is an invasive apocrine carcinoma that I had. You can see it's nice and strongly HER2 positive. And another example that typically, you don't think about lobulars being positive, but what about variant forms of lobular, right? So there are cases that maybe don't fit that mold, right? This is kind of a solid, almost variant form of lobular, has some signet ring cell features, right? Not classic, not your nice grade 1 nuclei, but a little bit variant form of ILC. And while it clearly has no expression for E-cadherin, you can see right here in that same tumor is strongly HER2 positive with strong membranous staining. And again, we're going to go over the scoring of the HER2 IHC in just a minute. So I just wanted to show, while there are tumors that typically are HER2 negative, like lobular carcinoma, right, there are tumors that don't necessarily fit that mold, and that's those variant forms of lobular carcinoma, right? This is another lobular carcinoma. You can see is clearly very strongly HER2 positive, but it doesn't have that classic nuclei. It does kind of have that single cell infiltrative pattern, very discohesive among itself, but it also has these kind of apocrine-like features, right? So this is one of those variant forms of ILC with apocrine cytologic features that is strongly HER2 positive. And while the vast majority of classic lobular carcinomas are HER2 negative, up to 20 to 30% reported in some places can be HER2 positive if it's a variant form and they're high grade. And the most commonly types of lobular carcinoma that are going to be HER2 positive are actually those variant ILCs that have high grade nuclei and apocrine features. So that's just a brief, touch about what you could expect or not expect in cases of HER2 positivity and negativity. So with that said, let's talk about the HER2 current IHC scoring guidelines according to the ASCO and CAP guidelines as of 2018 with the newest update that has come out. All right, so this is the current algorithm for HER2 IHC's testing. And the first thing that I want to mention is that you make sure you are scoring this on the invasive component. There are cases that are going to have 2+ and even 3+ staining in the in situ component, but it's important that you stay away from that and you strictly score the invasive component by the validated IHC assay. And let's talk about the different scores, which the first one is going to be a 0, right? And the score of 0 is really two different types. Either you're going to have absolutely no staining at all. That's easy. You look at it, I mean, there's nothing, there's no question, that's an IHC of 0. The other scenario is where you're going to have membrane staining that's basically very faint or barely perceptible in less than 10% of the cells. And a lot of times people say, well, what does that mean? What does that mean to be barely perceptible? Like at 60x, at 40x, at 20x, at 100x? What is barely perceptible? And I think barely perceptible should be at low power. If you cannot see anything at low power, then that's going to be a HER2 0. Okay, if you're going at 100x to find a little bit of membrane staining, that's not 1+, right? That's 0. So, and I'll show you a couple examples of that. So our next step up from that is IHC 1+, which is still considered negative. So even if you score anything as 0 or 1+, in reality, these two scores do not need reflex-ish studies. And 1+ also considered negative is incomplete membrane staining that is faint or barely perceptible in greater than 10% of the tumor cells. And the number of tumor cells is important. We'll talk about that later, but that greater than 10% is something that you really need to focus on and say, is greater than 10% of this tumor have expression? And that's going to be more important down the line, and I'll show you a very nice example of when that can be difficult. So our next level of scoring is going to be 2+, and this is really the category that's obviously going to give people the most trouble, and that's equivocal. And that's, when do I order CISH studies, right? You're saying, when do I order in situ hybridization versus when do I don't? And when do I just call it positive on the IHC? And this is where most people are going to have the most difficulty in making that distinction. But the definition of 2+ is weak to moderate complete membrane staining observed in greater than 10% of tumor cells. And I'll show you that sometimes that's not as easy as it reads, right? As many of you probably already know. And our last category is just outright IHC positive, IHC 3+ positive, which is defined as circumferential membrane staining that is complete and intense in greater than 10% of the tumor cells. And I want to highlight the word intense here because you say, well, what is intense? Is that subjective? How intense is it, right? And that matters. That's actually going to matter. How intense is it? And hopefully, again, we'll clear that up for you. So let's jump right into this, and this is going to be our first tumor. I'm going to show you an H&E for all the cases that I show as we're moving forward, just so you have an H&E correlate of the IHC that I'm going to show you. But you can see, right, this is an infiltrative carcinoma. It's got kind of a dense chronic inflammatory response. This is a poorly differentiated carcinoma, right, very ugly. And if we look at the IHC on this particular case, this is easy, right? This is a score of 0. This is blanket negative. All these tumor cells absolutely show 0 immunohistochemical reactivity. Okay, so this is an easy case. You can confidently say is HER2 negative, and you do not need to do anything else. So let's move on to our next case. This next case obviously is not as high grade, right? You have some nice, tubule formation. It's not really that ugly of nuclei. There's not really that many mitoses. This isn't too ugly for a tumor. You would expect this to be HER2 negative. And indeed it is. So you do your biomarker profile and you do your HER2, and the vast majority of it is completely negative. But then you see these small areas with this faint kind of weak membranous staining, but it's less than 10%, right? It's not enough. This is just a tiny focus in your biopsy that shows this. You should still score this as 0. This isn't really enough to call this 1+ when the vast majority of it doesn't really show any staining at all. So even if you have a little bit of staining, don't jump the gun and say, oh, there's some staining, I'm going to call it 1+, right? This really is a 0. It doesn't need anything other than that, and you can move on to the next case. All right, moving on to the next case, right? This looks very similar to our previous case that we just had, right? It's got some nice tubule formation, nuclei aren't too ugly. This is, again, it's not a tumor that you would expect to be HER2 positive. This is something that when you order your biomarkers, you would expect this to be strongly ER positive and HER2 negative. But then you get your IHC, and now we're kind of on to the next category, right? So this is a low power image. All right, this is a 4x image here, and you can see just on 4x, I can see staining. I see some reactivity in the tumor cells, and that's what I say should be perceptible, should be barely perceptible, faintly perceptible. I should not have to go to higher power to see some reactivity in these tumor cells. And if I go higher power and I look at these tumor cells, I do see that it is a little bit membranous, but it's not complete, right? Again, low power, it's barely perceptible. It is in greater than 10% of the tumor cells. In fact, the majority of this tumor shows a little bit of reactivity, but it's not complete, it's not strong, it's not moderate in intensity. This is a nice example of a 1+ tumor. And just another example of 1+, again, in this case, you can actually see that the immunohistochemical reaction is a little bit stronger than the previous case, right? The other one was a little bit weaker, so I'm showing you a little bit of scale of 1+. The difference here is that it's incomplete, right? It's not that strong. I wouldn't consider this moderate. There's no complete membranous staining. In fact, the majority of the tumor cells, or I shouldn't say the majority, but a lot of the tumor cells show very little reactivity at all. But it's all incomplete. It's all kind of faint. And it's, again, involving greater than 10% of the tumor cells, but 1+ is the correct category to place this. So let's move on to our next tumor. Our next tumor, you can see, doesn't have as much tubule formation, right? It's got more solid nests. It's got very ugly pleomorphic nuclei, kind of admixed with more moderate kind of grade 2 nuclei. And then you've got these bale grade 3 nuclei. This is a higher grade tumor than what we previously saw, right? But it's not very mitotically active. So this is a case where you're kind of like on histology, you should be on the fence. This could go either way, right? This could go either way. And then you do your IHC, and this is what you get back as the HER2 IHC studies. Now, in this case, you can see this is a little bit stronger than our previous case, right? This is more moderate intensity, but what do we notice about this? First and foremost, and I hope, compare this to the cases that I'll show you later, this is not intense, okay? This is moderate, and you obviously need to compare this to your internal control at your laboratory, but this is not intense, complete, strong, crisp membranous staining. It is complete in some of it, right? You have some cells here that show some nice complete membranous staining, but it's kind of that moderate intensity. And in fact, this case was in fact negative by in situ hybridization. So in regards to the 2+, right, we think about these cases, and this is where things can start to get a little bit tricky, right? You start seeing cases like this, and this is a low power. You can see there is clearly some staining, and when you go on higher power, you see, okay, there is some weak kind of complete membranous staining in some of this, and you ask yourself, is it greater than 10%? And if it's greater than 10%, then technically I call this equivocal, and then I would do ISH, and I would try to interpret the ISH in these areas, right? And this is actually the lymph node that goes along with the previous slide. So the previous slide was the breast excision on this patient, and this was actually the axillary lymph node with an axillary met that was predominantly 1+ staining, right? And, as I looked throughout this lymph node, there was enough of this that I thought there was enough greater than 10% to say, you know what, let's go ahead and test this too. And the reason I say that is I say, well, she's got clearly 2+ staining in the breast, and then I have some 2+ staining in the lymph node. So do you try to combine those to come up with is it greater than 10%? Because the vast majority of the excision in the breast was 2+, and what's in the lymph node, there's some 2+. So I give them the benefit of the doubt in that scenario because I'm thinking about the patient as a whole. The patient clearly has some equivocal staining, and in this case I decided to test both of which were negative by in situ hybridization. And this is another example, right? So this is another example compared to the previous case. This is a different case now. You can see now the staining is a little bit more moderate, right? It's a little bit stronger than the previous case I showed, a more crisp, nice, clear, complete membranous staining. And again, what you need to ask yourself in these cases is it greater than 10%? Because this over here is clearly not 2+, right? This entire area, and even this down here and all this right here. Does this compromise more than 10% of the tumor? So in these cases that are heterogeneous, you really need to focus on, is this greater than 10%? And then when you do your in situ hybridization studies, if you, determine that you think that this represents greater than 10% of the tumors, then you're going to need to focus your ISH studies in those areas of the tumor. This is just another example of a case that I called 2+. This is a little bit weaker, right? This is, to me, on the lower end of 2+. This is weak. You can see that some of it is complete. It's almost a little bit granular at times. You would say, okay, in this particular cell, does it fall off right there? What is complete, right? But the thing about this is almost all of the tumor kind of shows this weak IHC, faint kind of perceptible pattern. It's not heterogeneous. You can say that comfortably this case is 2+. It's got weak, complete membranous staining in the majority of the tumor. And we'll go ahead and go to ISH studies, and in this case again, this was a case that was negative by in situ hybridization. So now let's show the kind of upper end of HER2 2+, right? And this is a case where you say, wow, some of this looks pretty strong on low power. And if you look, that's nice and crisp. You're really approaching the upper end of 2+ in this case. And the reason you want to be careful in cases like this, and again, as we compare it to the 3+, very strong, intense cases that you should be able to comfortably call 3+ by IHC, the difference in this case is that, there were these, kind of cells scattered throughout here that showed this kind of strong staining, some of it moderate, but you have these cells that are nice and complete, but then you have other cells that aren't, right? So this is a little bit more granular here. You can see this cell has a nice strong membrane right here, and then it's negative on the top here. If you look at, this is all from the same case. And if you look up here, this area is a little bit more granular. You can see this nice crisp membrane staining in this cell right here, but all of these other cells, they're not really nice and crisp and membranous, right? In the sense of what we want for 3+, and the intensity is not there. It's approaching it, but it's not there. And this is, you can see that throughout here, it's not complete, right? You have this kind of U-shaped, kind of intense staining of this membrane here, and it's negative on the top. Again, this is kind of that upper end of what we would call 2+, and I thought this was a good example to show that upper end, because this was a case, again, that was negative by in situ hybridization. So let's move on to our next category, and our next category is going to be obviously the HER2 positive cases. And again, something that should trigger your thought, oh, this might be HER2 positive, is as you approach those higher grade tumors, right? Nice mitotically active, kind of pleomorphic, large, ugly, ugly looking tumors that have that higher propensity to be grade 3 and higher propensity to be either triple negative or HER2 positive. So if we look at the HER2 IHC in cases like this is intense, right? This is unmistakably crisp membrane staining, circumferential around all of the tumor. This is not heterogeneous. This is 100% of the tumor displaying strong circumferential staining. And again, another example of just a high grade, grade 3 invasive ductal carcinoma with, again, strong, complete membranous staining. It's unmistakable. These are the cases, honestly, that shouldn't give you much trouble, right? These are cases that should be straightforward. You can make a decision comfortably. These are the patients that are going to respond to therapy very well. In fact, these are the type of cases that are actually quite remarkable, right? I mean, this again is another case I had, very high grade, grade 3 invasive ductal carcinoma, highly mitotically active, pleomorphic nuclei, super ugly. I mean, look how big these nuclei are compared to the just surrounding lymphocytes. These are nasty. These are bad looking tumors. And then you do your biomarkers and you get this IHC, and it almost makes you feel good. You say, oh, thank God she's got a treatment option that's really going to work, right? Because all of this tumor is strongly expressing HER2, and it's a miracle. This is the same case. Patient gets Herceptin neoadjuvant therapy. The lymph node that was biopsied, the tumor bed is completely wiped out. There's no residual tumor, a YPT 0. These are remarkable cases. It's honestly, it takes these diseases that have such a poor prognosis historically and gives them a good prognosis currently. So for the rest of this, I want to focus on some unusual scenarios that you might see, and I want to share kind of my approach with these and kind of give you my thought process and how do I give this information to the clinician, because there's a lot of cases that don't necessarily fit perfectly into this nice mold of saying, hey, this is HER2 3+, or oh, this is HER2 2+, no problem. Right? There's a lot of cases when you start practicing and you start signing out a lot of these, as I do, signing out probably 15 to 20 biomarkers a day, it's not uncommon to see cases that don't fit that perfect mold, right? And these are the cases that I want to talk about, I want to show you, and hopefully help you through my thought process and how I approach these. So let's take a look at this invasive cancer right here as an example. Okay, so you have some invasive carcinoma in this kind of dense, stroma. It's got a little bit of desmoplastic response to it, but this isn't necessarily a very ugly tumor. You could say it has a lot of eosinophilic cytoplasm, but it's not too ugly. And let's look at the HER2 IHC for this case. So here you go. You get this on your biomarkers, and you look at low power, and your first thought is like, oh, that's 3 plus. And in fact, the automated system called this 3 plus. So if you run with just an automated system and you don't have someone looking at the slide, this may be mistaken for 3 plus. But let's take a closer look at this. If we look on higher power, I ask you, do you see any membranous staining? And the answer is no. Right, this is all granular cytoplasmic staining, and this particular tumor sort of had like an apocrine morphology to it. And the HER2 I've seen in these apocrine type tumors, while they can be nice and strongly 3 plus positive, as I've mentioned earlier, sometimes you'll see these carcinomas that have this unusual granular cytoplasmic staining. And what do you do with that? Do you call this 2 plus? Do you call it 1 plus? And the answer is you call it 0, right? There's literally no membrane staining. And you should remember that HER2 IHC scoring is based on membrane staining. There is no membrane staining in this tumor. This is all cytoplasmic granular nonspecific staining. And I actually put a comment on these cases. I will call them HER2 score 0, and I'll say a comment. I'll say HER2 IHC shows nonspecific granular staining. And why do I do that? I do that because what if this case goes somewhere, someone looks at it on 4X, they potentially think it's 3 plus, and then they look at the report and they say, wait, it was 0. Well, how is it 0? Oh, nonspecific granular staining, and they look higher power and they see exactly what I'm talking about. So I try to illustrate that more for any future pathologist that may come across this case than the clinical oncologist. The real thing you need to know is that these cases are HER2 negative. Let's look at another unusual scenario, and I touched on this a little bit earlier in cases that have these mucinous and micropapillary features. So this particular tumor is actually in a lymph node in this particular image, but you can see all this mucin associated with the neoplasm, and it has this kind of subtle micropapillary architecture to the tumor cells, very little kind of clearing around these clusters of tumor cells, and it has this micropapillary architecture. And one of the morphologies that you can see with HER2 immunohistochemical studies that is specifically addressed in the ASCO guidelines is what they call moderate basolateral staining in tumors of this morphology. And that's exactly what you see here. So in this particular case, you can see that, we have this is actually pretty crisp, right? Nice and clear membrane staining around these tumor cells that is just kind of missing off the top, right? Missing off the top, missing off the top, all that. It's kind of missing right there on the top of these tumor cells. So if that's not basolateral staining, I'm not really sure what is, right? Because you have everything staining except for the top of the tumor cells, okay? And this is called moderate basolateral staining in cases that have been shown to be HER2 positive by in situ hybridization. And in this case in particular, this actually was positive by in situ hybridization. It had a ratio of 2.1. And that's a low level of amplification, okay? And in this particular case, the patient did have a trial at Herceptin therapy and didn't really respond well. So it's something that I think going forward will continue to evolve, right? Because I think historically, you may have looked at this and may have said, oh, that's 1 plus, right? But by definition, by the current definition of the ASCO guidelines, if you have a micropapillary architecture and it has this moderate basolateral staining, they're saying that you could consider that 2 plus. So in these scenarios, and I've seen multiple of these, okay, so I've seen many cases like this, and honestly, the vast majority of them are HER2 negative by-ish, but this particular case was positive. So now you've given them this HER2 treatment option for therapy for this patient. The question that I ask, and the question you should ask, and have that dialogue with your clinicians, I encourage you to talk to them. Hey, did she respond? Did you see any response to the tumor? That's the question that I think future trials are going to talk about and further elucidate in cancers like this. This particular patient did not respond to Herceptin therapy. The tumor got a little bit larger and it didn't have the response that you would expect, say, in a patient that has strong 3 plus staining in the entirety of the tumor, right? This isn't strong. It's not very intense. It's not complete membranous, but again, as I mentioned, this was subtly amplified. So if you look at just an excerpt of the ASCO guidelines, the 2018 guidelines, right, it talks about these unusual staining patterns of HER2 by IHC. And it says, they're rare, but if encountered, you should consider it equivocal. And one of them is the one I just showed you. So specific subtypes of breast cancers can show IHC staining that is moderate to intense, but incomplete, basolateral or lateral, can be found to HER2 amplified. That exactly was the case that I just showed you. It had basolateral moderate staining and was found to be HER2 amplified. But as I mentioned, that patient didn't respond. So I asked myself, how is this going to be treated going forward? Are we going to have enough of these cases to determine, is that enough? That patient, yes, she's amplified. Or are we going to develop drugs that target Herceptin better or HER2 better than Herceptin, and they'll respond even better? Those are questions that I think will evolve over time. And another example that I want to talk about is cases that, again, don't fit that nice algorithm. It's got super strong membranous staining, but in less than 10%. Right? What do we do with that? How do you relay that to the clinicians? And what they say here is, another example, again, that should be considered equivocal are cases of strong circumferential staining, but less than 10% of the tumor cells. So let me show you a case I had. And again, this is a, nasty looking tumor. It's got like a neuroendocrine type morphology to it, highly mitotically active, solid tumor in the breast. And this is your biomarker profiles. This is what you get. So now you have a case that's got HER2, and again, it's hard to illustrate the percentage on a PowerPoint slide, but I'll try to do that for you. But you can see over here, right, you have this very strong 3+, no doubt, membranous staining, and in fact the rest of the tumor is almost zero, right? Maybe some 1+ over here, but zero almost everywhere else. So if you look at that little focus, I mean, this is unequivocally HER2 strong, membranous complete, 3+ staining, right? No doubt. But you look all around, the rest of the tumor is essentially a zero. So what do you do here? How do you approach this? What information do you give the clinician? So you call this, you say, oh, well, I guess by the ASCO 2018 guidelines, it's 2+. So do you just say HER2 2+ and sign it out? Or do you give them more information? And one of the things that I would encourage you to do in cases like this, the very first thing you should do is take another section of the tumor and do IHC on that as well. Because now, instead of just testing one block, you've tested two, maybe you have a better idea of the percentage. Maybe you test the next block and the whole block is HER2 positive, and you're more comfortable to say, hey, this is HER2 positive. But in theory, let's say that that doesn't happen, and that's what did not happen in this case, because that's what I did. And that's what didn't happen in this case, is that area of HER2 positivity by IHC was probably 5% of the tumor. So what do you do? How do you relay that to the clinician? And as I mentioned, and I showed you in the current guidelines, it's recommended to refer these as equivocal. So if you refer it to as equivocal, you're going to do in situ hybridization. And if you do that, you're obviously going to focus your ISH studies on the strongest area. And if you do that, it's clearly going to be amplified in that 3+ area. But everywhere else, it's negative, as in this case. And that's the way it was. And in that area that was strongly 3+, it was amplified by ISH. And in the area that it wasn't 3+, it was totally negative. Right? And these are the cases that make you wonder, what do I say? What do I say to paint the right picture and tell them what I'm seeing? Right? Because if I say, oh, it's HER2 2+ and it's FISH amplified, does that give them the entire story of what we're seeing? And I would tell you that it doesn't, right? And what I would recommend is that these are the type of cases that really deserve a comment. They deserve you to explain what you're seeing, right? You say, okay, HER2 is 2+, see comment. And in that comment, you say HER2 immunohistochemical studies show heterogeneous staining with strong 3+ complete membranous staining in less than 5% of the tumor cells, while the remainder of the tumor shows 0 to 1+ staining. Okay, and what that tells them, or what that should tell them, is that, okay, this obviously has some positivity by HER2 expression, but the vast majority of the tumor does not express HER2, and I wouldn't expect this patient to respond to HER2 therapy like I would a patient that's strongly 3+ and 100% of the tumor cells. And you could do the same thing with the ISH in this case, right? And they say, okay, well, when you evaluate ISH, you have to say, is the ISH greater than 10% of the tumor? And I think that becomes a very challenging thing to do on ISH. FISH because we're counting 20 cells, and to count 20 cells as a area is this 10% of this entire slide at the cellular level on ISH studies or FISH studies becomes very challenging, right? And in this particular case, you ask yourself, well, do I want to withhold therapy? Do I want to call her negative, right, and say you don't get Herceptin as a treatment option? And I would say that that's probably the wrong thing to do, because there is clearly a component of this tumor that would respond to Herceptin treatment, but she has a huge component of this tumor that's not going to respond to therapy. And I think your best bet as a pathologist is to just illustrate what you're seeing, that there's heterogeneous IHC staining and there's heterogeneous gene amplification in this tumor. And that gives them the ammo and the tools they need to make their decisions. We can try Herceptin. There's a chance that you won't respond. And if you don't respond, we move on. And in this particular case, this patient actually passed away 3 years later, and I had several biopsies from this patient that were actually triple negative metastasis. So she had metastatic disease, and the metastatic disease wasn't even a HER2, 1+. It was a 0. It was a, ER/PR HER2 0. And these are the cases that are going to make you think, am I giving them the right information? Am I presenting this in a way that's going to help this patient? And I think that if you approach it like that, and if you present what you see, out in those cases that don't necessarily fit the mold very well, then you're going to give the clinicians a clear picture of what you're seeing. If you simply say it's equivocal and FISH is positive, you may give them high hopes because they've had these cases that have had complete responses to Herceptin therapy. And I think that's very important, and I think this case in particular illustrates the importance of that for not only the clinicians that are treating the patient, but also the patients and their families and their expectations of the disease that they have going forward. I tried to make this brief. I guess we're at about 40 minutes, but I could talk about breast pathology all day, it seems. But I thank you guys for hanging around. I hope you enjoyed it. I hope you found it helpful, first and foremost. And I hope this kind of gives you a little bit of guidance on how to approach these cases. And if you enjoy my lectures, as always, feel free to like and subscribe, and I'll try to load things up. I don't get to load cases as often as I would like, but I'm also on Twitter. I post some breast pathology cases on there. You can follow me at @DamronMD as well, and I tend to post some Don't Rush Breast Case Series, and I'll post some educational content on there. And also, special thanks to Paul Stevens in my lab, who helped gather all of these cases that we've had throughout the years to kind of put this lecture together. And big thanks to him. So I appreciate it, and I hope you all enjoyed it, and hopefully I'll see you next time.